الله الرحمن الرحيم. يسعدني أن أرأس هذه الجلسة مع الأخ العزيز الأستاذ الدكتور أحمد أبو نجدة والأستاذ الدكتور ياسر مصطفى. ويسعدني طبعا أن أقدم أخ عزيز ليا جدا ومؤسس من مؤسسين جمعية الشعب الهوائية الدكتور مجدي إدريس. الدكتور مجدي إدريس هو الهيد of the Department of Chest Diseases, Pulmonary Diseases في الرياض في الناشونال جارد هوسبيتال، وهو الهيد برضه بريزيدنت بتاع الساف اللي هي السعودي اسوشيشن Pulmonary Hypertension. وزي ما احنا عارفين هو اكسبرت، تحب انت كلمه اكسبرت اكسبرت في موضوع Pulmonary Hypertension، وحقيقي من الاثوريتيز اللي احنا بنحترمها جدا، ودايما بيساعدنا بمحاضراته الجميله، ودايما بتبقى متواجد معانا يا دكتور مجدي. فدكتور مجدي هيدينا ريفيو او هيدينا talk about current and future therapies for PAH، ومفروض في بعديه recent advances in portal pulmonary لسه ما جاش، وبعديه الاستاذ الدكتور ياسر مصطفى الابديتس on anticoagulation therapy of pulmonary embolism.
Assalamu alaikum, everybody. It's actually a great honor to be here. First of all, I'd like to thank very much my very dear friend, Dr. Taq Safwat and Dr. Abdul Khattab. They are friends, teachers, really buddies, whatever you want to call it. We really appreciate the long-term relationship between the Bronchology Society and the Saudi activities. It's again an honor to be in the new Egypt. We are all proud about the new Egypt with the new era. And we are all supporting you, and we wish you all the best, inshallah. In the coming 25 minutes or so, I was asked to talk about the pulmonary hypertension, the current and future therapy. And before I start talking about this, let's have a baseline agreement about what is pulmonary hypertension. And if you look at it, if you look at the data, pulmonary hypertension is not a disease. Pulmonary hypertension is a hemodynamic status, that is a measurement of the mean pulmonary artery pressure of more than or equal to 25 millimeter of mercury. And this is measured by right heart cath. So the first really lesson from this slide is that you need a right heart cath to make a diagnosis of pulmonary hypertension. Echocardiography is a good screening tool, but it should never, and again I'm saying never, should be the diagnostic test for a pulmonary hypertension. If you look at the pulmonary hypertension, it is not one disease. It's actually many syndrome or diseases can present with this hemodynamic state. And according to the recent classification, there is 5 groups for the pulmonary hypertension. Group 1, it's the only group that we call it as pulmonary arterial hypertension. And those are those who are related to the idiopathic form of the disease that we used to call primary pulmonary hypertension. Nowadays we call it idiopathic pulmonary arterial hypertension. There is the heritable causes, and there is the associated with other diseases such as PAH, pulmonary arterial hypertension, secondary to connective tissue diseases, infection, mostly HIV or schistosomiasis, hemolytic anemia, congenital heart disease, etc. Now the second group is the pulmonary hypertension due to left-sided heart disease, and that's what we call the post-capillary. And again, it is the only one that is the post-capillary pulmonary hypertension. And it is the only one or group that we have high wedge pressure when we measure it through right heart cath. It is the most common cause of the pulmonary hypertension, and about 80% of really pulmonary hypertension belongs to group 2 disease. Group 3 disease are those caused by or due to hypoxia or lung diseases such as COPD, interstitial lung disease, sleep apnea, high altitude, etc. Group 4 are solely due to chronic thromboembolic lung diseases, and group 5 are those that we call miscellaneous, or they are related to systemic diseases or multifocal manifestations such as sarcoidosis, certain vasculitis, renal failure on dialysis, etc. So it's very important when we talk about really pulmonary hypertension to know we are talking about which group, because treatment for each group is very, very different than the other group. And largely in this talk, we're going to talk about group 1, or the pulmonary arterial hypertension disease. It's important, I believe personally, is to understand the basic pathobiology of the disease before we start treating it. And if you look at the data, looking at the pathobiological point of view, the initial important part is vascular tone versus remodeling. That these are the initial hits that happen and that lead to changes in the vascular tone of the disease. And if these two pathology are allowed to continue, then changing in the pulmonary vasculature will happen, increase in the pulmonary vascular resistance, and at the end of the day, development of the pulmonary hypertension. Now let's talk about the first part, which is the vascular tone of the disease that can happen during early stage of the disease. And that's simply that initial injury that happened changed the, if you like, the delicate balance between the vasodilator and the vasoconstrictor. Normally, these mediators, the vasodilator, usually nitric oxide, prostacyclin, and others, are in delicate balance with the vasoconstrictor to maintain the tone of the pulmonary vasculature. What happened after the initial hit or the initial injury, that this balance is disturbed, and there is overregulation of the vasoconstrictor, increase in the endothelin-1, basically serotonin, angiotensin, and other mediators, and there will be underregulation of the vasodilator. This will definitely lead to increased vascular tone, which is only the initial step of the disease. But what happened most importantly later on, that the disease progressed with more remodeled proliferation phase, that now you do start having proliferation of the cell layers, and that will lead to the pulmonary vascular, if you like, disease itself. Looking to what happened, it's actually, if you look at it, it is a very malignant process. Number one, the apoptosis balance or the programmed cell death changed. That those cells don't die anymore. They stay longer, or they live longer and longer, and they proliferate more and more. So the balance between programmed cell death and the new generation of the cells is basically disturbed. Now, secondly, what really happened, proliferation of all cell layers, intima, media, and basically adventitia, all of them proliferate significantly to completely occlude the pulmonary vasculature. And then rapid or uncontrolled partial recanalization happened. And that's combination called plexiform lesion. That's thought to be the pathognomic of the disease. That what really make the disease characteristic is the form of the plexiform lesion in the pulmonary vasculature. Now, when we look at this plexiform lesion, it's full of growth factor. And in this paper, when they look at the phenotypically altered nuclei and they stain it basically for many growth factor, it's really grained very positive, stained very positive for many, many growth factor, such as platelet-derived growth factor, vascular-derived growth factor, and other growth factor as well. So it is truly malignant process. The only difference between malignancy and lung cancer is malignancy is monoclonal proliferation, while here it is oligoclonal proliferation. But it is definitely metastatic, malignant process. It also differs in the absence of metastasis. There is no metastasis so far of the pulmonary hypertension to affect basically other vessels. A little bit more about those growth factors that modify the proliferation of the cell layers in the pulmonary vasculature. There is data to show that they also stimulate the attraction of the inflammatory cells, creating an inflammatory media within the pulmonary circulation. Now, this proliferation phase create new vessels in the pulmonary circle. But these vessels are unlike the normal, delicate, basically pulmonary capillary where the endothelium is lining those vessels. There is a mesh, if you like, of a new vessel formed in the lungs. But these vessels are very abnormal vessels, so really they don't have blood moving in the normal way. So the oxygenation is really not perfect. The gas exchange, the VQ mismatching is becoming more and more disturbed over time. There is one special form of those mediators, growth factor, that I would like to really emphasize, that are the tyrosine kinase, basically stimulus. Because these are now might be the target of therapy in future. If you look at it, it is a form of vascular endothelial growth factor. But why they are important? Because there is now a new data that trying to target those mediators that are growth factor mediator can probably change or improve the disease. And there was one study came from Germany looking at patients who were doing very bad on maximum therapy. And at that time, the author used imatinib, which is tyrosine kinase inhibitors. And then they found that those patients who were in function class 4 before starting imatinib, which is chemotherapy, it's basically anti-tyrosine kinase, there is significant improvement in their function class, their 6-minute walking exercise improved, and more importantly, if you like, at their basically pulmonary vascular resistance, it dropped significantly in those patients. So maybe in future, we're going to use a lot of treatment with this kind of chemotherapy agent in treating basically pulmonary hypertension. So vascular tone is one. Number 2 is the vascular growth factor. But there's also another important hit, which is the shear stress. And what we mean by shear stress is the velocity of blood that flow across the pulmonary artery. Normally, the speed of the blood flow change the shape of the endothelium. It's called endothelium deformity. And depends on this, the normal endothelium secrete vasodilator to improve the tone. So when we exercise, the flow increase, our endothelium sense that vasodilate accordingly. But if this is allowed to be a continuous process for a long time, such as what happened in congenital heart disease, these endothelial cells get injured and they start behaving abnormally in the way that they start secreting a lot of vascular endothelial growth factors, such as transforming growth factor beta, TGF-beta, and other growth factor. They start having disturbed anticoagulation process in the way that they start having decreased nitric oxide, decreased prostacyclin production, which is supposed to be having anticoagulant effect. So you start having in situ thrombosis. So this kind of shear stress now is recognized as one of important, basically, if you like, signal in the pathobiology of the disease. And finally, talking about genetics, because we know that not everybody who get this initial hit of, for example, schistosomiasis or HIV or scleroderma get pulmonary hypertension. So it need to have some genetic predisposition. And there is many genetics or many genes now they've been identified, but the most important one is the BMPR2 receptors, a mutation. And let me discuss with you a little bit, because this is a very important aspect. Now, nowadays we start working on it, even in Saudi Arabia. Now, the idea of this gene, it is a protective, basically a protective gene. The idea is to maintain the integrity of the endothelial cells, so to prevent those growth factors to penetrate inside to start stimulating the proliferation. So whenever you have a mutation in this gene, what happens, the integrity of these endothelial cells get affected. So over time, these growth factors start getting inside and stimulate the respiratory muscle growth. And over time, there will be apoptosis, basically stimulation or basic inhibition, more endothelial cell injury, and then you will get the pulmonary vascular disease. So this gene mutation is becoming very, very important as a risk factor. It's not a cause, but it is a risk factor for the development of the pulmonary hypertension. So in summary to this basically pathobiological disease, we know that there is an initial hit, initial injury that basically happened. It could be idiopathic, it could be inflammatory, it could be infective, it could be clotting process, injured the endothelial cells, changing basically the tone. Over time, there will be growth factor, basically stimulation, proliferation, and then over time, apoptosis resistance, which is a very malignant process, finally complete occlusion, and what we call plexiform lesion, basically formation. Now, these changes in the pulmonary vasculature, the effect or the killing phase of this is not because what's happening in the lung. It's because how the heart will adapt to this increase in the pulmonary vascular resistance. And we know that the heart, mainly the right ventricle, which is usually thin and kind of a small chamber, start to hypertrophy, start to really dilate, trying to adapt with this increase of pressure. And this is what happened in those patients. Initially, the PVR, the pulmonary vascular resistance, increased gradually. The symptoms could be initially subtle because the cardiac output is maintained, but the pulmonary artery pressure is going up over time. Now, once the cardiac output starts going down, then the disease starts to be having a lot of symptoms and the mortality becomes very high. But I'm going to draw your attention to one important point here. Look what happened to the pulmonary artery pressure at the end of the day. When it's near fatal attack, it starts coming down. And we sometimes find these in our cardiology colleague doing echo, and they're saying pressure was 80 and now it is basically 50, but the patient is getting worse. And they're saying, look, the echo is getting better because the pressure is coming down. Now, this is a very bad sign because that means that the cardiac output is going too low and now the pulmonary artery pressure going down, which is not a good sign at all. And the data show that whenever you have this combination of low pressure going down with a right-sided heart failure, the mortality becomes extremely high in those patients. So how we manage this disease, how we can deal with this process on clinical practice. First of all, we need to establish the diagnosis. And again, I'm really emphasizing it is the right heart cath, which is the diagnostic test for those patients. It is not echo. Echo is only screening test that we do initially. Then we need to classify it into one of those basically 5 groups because we need to know if it's basically the pulmonary arterial hypertension group 1 or the cardiac or the lung or the chronic thromboembolic or the miscellaneous basically disease. So we need to put it in certain categories. Then we need to evaluate the severity based on many factors, the functional class, the 6-minute walk distance, certain biomarkers. There is echo, there is right heart cath criteria, and these are very important. The reason they are very important because they will define what we call the patient status. And before we start treatment, we need to know where is our patient, belongs to which basically group. What we want our patients to be always in the green zone here, that they have minimal symptoms, no signs of right-sided heart failure, including syncope. They should be able to walk for about 500 meters or more. They need to have very normal or close to normal BNP level. And you would like them to have, by the echo, no pericardial effusion, and what we call the TAPSE scoring, the movement of the tricuspid annulus is more than 2 centimeters, indicating good right ventricular contraction. And we would like them to have good hemodynamics, that cardiac index more than 2.5, and right atrial pressure is less than 8. Whenever patients are drifting into the red zone, we need to modify treatment to bring them back into the green zone. So how we do that? Basically, to be honest, we do that by right heart cath again. So the right heart cath is not only diagnostic, it will guide us to where we go in therapy. And if you look at it, we do what we call vasoreactive testing to know is the patient is basically vasodilator phase or he or she in the remodeled phase. And simply we do short-acting vasodilator, usually nitric oxide, but you can use inhaled iloprost or adenosine or even IV prostacyclin, and try to see if we can decrease the pulmonary artery pressure by more than 10 millimeter to get the absolute number below 40. So somebody start with a mean pressure of, let's say, 50. If we give nitric oxide and then the pressure dropped to really 35, that's very good, provided there's no difference or there's increase in the cardiac index or the cardiac output. So there should be no drop in the cardiac output. And if the patient behave like this, they are vasoreactive, indicate they are mostly having vascular tone problem, then the treatment is a calcium channel blocker. And we go quite a high dose in the calcium channel blocker management. It's very important to really note at when you use this drug, those patients, they have very good prognosis. And as you can see that their 10-year survival is about 95%. That's excellent. So those patients who are vasoreactive, treatment is very simple. It is calcium channel blocker, and their outcome is perfect. Unfortunately, they are less than 5% of the total patient, 5 to 10%. So the vast majority of patients will not vasoreact. So whenever we see them late, they have their fibrotic disease, and we need to use antifibrotic treatment, or what we call the targeted, basically, therapy, targeting one of the three pathways, either the prostacyclin pathway to maintain the cyclic AMP, which is vasodilator and anti-remodel drug, or nitric oxide pathway to maintain the cyclic GMP, or the endothelin pathway to inhibit the endothelin pathway, which is very promotive for basically proliferation and vasoconstriction. Quick data on the prostacyclin. The standard drug is the intravenous prostacyclin, epoprostenol, or really the Flolan. And this drug was a major breakthrough in the mid-90s because it was the first drug which showed significant survival advantage. As you can see, the 3-year survival improved from 30% to 60%. So we doubled the survival by using continuous intravenous prostacyclin treatment in those patients. But the problem with this mode of drug, really delivery, that it needs an indwelling catheter, of course, with all the complication of really infection, clotting, etc. Furthermore, because you stimulate the receptor continuously, if there is abrupt delivery of the treatment, a rebound process can really happen, which could be fatal in as short as few minutes. So you need to be sure that you are delivering the drug continuously and you have an alternative access if anything went wrong with those patients. There is other basically prostacyclin analog, such as the sub-Q infusion that we use more commonly in Saudi Arabia, and we have the inhaled ileoprost. The problem with it that it needs to be given 9 times a day, 6 to 9 times a day. But it is another way to give prostacyclin, and it is much safer than the intravenous prostacyclin. The AIR study was the first study to show, which get the FDA approval for the inhaled ileoprost, that patients who were using the inhaled ileoprost walk significantly longer, indicating better cardiac output than those who were in placebo. And there is worsening endpoints such as the escalation of the disease, the death, the need for lung transplantation was much lower than those who were on placebo. So this was the first drug to say that inhaled ileoprost could be an alternative to the intravenous prostacyclin. The second class of drug is the endothelial antagonist, and those drugs inhibit the endothelin receptors A and B that are present on the smooth muscle, because stimulation of this receptor by the endothelin pathway lead to vasoconstriction and the proliferation and stimulation of the smooth muscle proliferation. So inhibition of these receptors will lead to the opposite. And if you look at the BREATHE-1 study that addressed this issue using bosentan as the first-line treatment in the patient with idiopathic pulmonary arterial hypertension, data has shown that bosentan was far superior than placebo in improving the 6-minute walk distance and decrease the clinical worsening attack. And bosentan is an FDA approved for the treatment of the pulmonary hypertension. A BREATHE-5 study addressed the use of bosentan in congenital heart disease, and again it looked at those who were treated with really bosentan there is significant drop in their PVR compared to those who were on placebo, that there was increase in the PVR over 16 weeks period. But the early study was an extremely important study in the bosentan area, because in this study, they tested using bosentan in somebody who were almost asymptomatic. And they were trying to see if we can modify the disease progression by using bosentan. And what they found that even in this very early disease, this was a 12-week study. And if you look at it, those patients, although they were very, very early, if you don't treat them, within few weeks, their PVR increase, indicating that the disease is very progressive at a very early stage. Using bosentan decrease the PVR elevation significantly. And nowadays, we learn that maybe we need to start treating patients not at stage 3 or 4, but at stage 1 or 2 because of the early study. Finally, we have the sildenafil pathway or the nitric oxide pathway trying to inhibit basically the phosphodiesterase 5 enzyme. Now we know that the cyclic GMP, which is the good molecule that leading to vasodilatation, inhibits smooth muscle proliferation, is accumulated through nitric oxide pathway. However, normally, this molecule is being degraded by the phosphodiesterase enzyme, trying to not allowing a lot of nitric oxide and cyclic GMP. So what we're doing is trying to inhibit this enzyme by using sildenafil or the tadalafil or any one of those phosphodiesterase 5 inhibitors. Recently, there is another drug called riociguat that work on the stimulation of development of more basically cyclic GMP. The sildenafil study was tested in the super study by basically R.D. Warfarin in the New England, and showed that this drug, by use of 3 different dosing, 20 milligram TID, 40 milligram TID, or 80 milligram TID, get very good response. When you look at the 6-minute walk distance, basically improvement. From the other hand, using riociguat, which is still in phase 4 trial, it will be in the market very, very soon, showed that this drug is very, very effective in decreasing the PVR at 2 different doses, 1 milligram and 2.5 milligram orally. The problem, it also decreased the systemic vascular resistance. But that was basically balanced by significant increase in the cardiac output. So very few patients get really hypotension with it. The second important part of this riociguat treatment, it was the only drug that was tested in the chronic thromboembolic, which are group 4 disease, and showed that compared to the nitric oxide, it significantly increased cardiac output. So we are all looking for this drug to be in the market very soon. So what happens if the patient fails treatment with this drug, the target drug? The recommendations say you start combining these 2 drugs basically together. And R.D. Warfarin look at this data in the cath lab when he gave and basically inhaled iloprost and showed that the PVR goes down very nicely for about half an hour. Then it lost basically the effect. However, adding sildenafil, again, it dropped that nicely. Adding another iloprost maintained the effect for about 3 hours. And now we learned that probably if you combine sildenafil and really iloprost, you don't need to give iloprost 6 to 9 times a day. And that was also reflected on the clinical ground, that you can see that using iloprost improved 6 minutes, that was lost over 3 months' time. Adding sildenafil maintained the effect for really 1-year treatment. So my take-home messages to you is basically the following. We need really to treat the pulmonary hypertension as a malignant disease. It's very fatal disease. If you look at it, those patients who die comparable to metastatic lung cancer. If you get lung cancer metastatic compared to advanced pulmonary hypertension, the survival in both groups is about 6 months. So it's highly fatal disease. We need to understand the pathobiology of the disease, and we did talk about the 4 important aspects that we understand at the moment, that is the vascular tone, growth factor, really stimulation, shear stress, and the genetic. But definitely there is much more to go. There's a lot of new theories about other signals in the disease. We need to have a significant approach or algorithmic approach in understanding and approaching the patient, looking for clinical signs, symptoms, imaging processes. Echo is very good in the initial screening, basically phase. Biomarkers are very important, but it is really the right heart cath that is extremely important to make a diagnosis and to classify the patient status. Treatment at the moment is directed towards two parts: the vasomotor control, and these could be achieved by the calcium channel blocker, but also by the sildenafil, bosentan, and prostacyclin, that they do have vasodilator activities, but also towards anti-remodeling effect, again, the prostacyclin, phosphodiesterase inhibitor, endothelin, and nowadays the new chemotherapy, tyrosine kinase inhibitors. There is a lot of drugs are coming in the near future. We have one drug called macitentan, and macitentan will be available soon. It is a new generation of the bosentan. It is more potent. We have basically helixipag, which is an oral drug to stimulate prostacyclin treatment, a newer prostacyclin through oral and nebulized form, and a newer tyrosine kinase. And thank you very much for your attention.
Thank you very much, Dr. Magdi, for a very elegant expose on a very important subject, the PAH problem. And I think we have a few minutes for any questions from the floor. Any questions to Dr. Magdi? Well, let me start with the first question, Magdi. We face a lot of non-PAH problems in, not PH, non-PAH.
Right.
Especially group 3 with interstitial lung diseases and severe interstitial lung diseases.
Right.
With an out of proportion pulmonary pressure,
Right.
more than 45. So what would you recommend, especially with the cost benefit, and what do you recommend for, in our situation in Egypt, we cannot afford, of course. I know the out of proportion, you should hospitalize them, and they should be under control for the non-PH,
Right.
to test them with the other products of the PH group.
Right.
So
Correct.
in our situation, usually we use the sildenafil or the phosphodiesterase 5 inhibitors.
Right.
So do you have any recommendation concerning this group of?
Sure. Thank you very much. The question is about the out of proportion for group 3 disease, i.e. we all know that if you have COPD or interstitial lung disease or sleep apnea, people can get over time mild pulmonary hypertension. But some of those patients, they have minimal changes in their lung function. For example, they have COPD, and their FEV1 is in the range of 65% or something, but they have a severe pulmonary hypertension. And we call that out of proportion. This pulmonary hypertension is probably not completely related to this respiratory disease. And then the question will be what to do. Do those patients, they have group 1 and group 3 at the same time? Or it is just a group 3, but unusually present with severe pulmonary hypertension? Definitely, as you rightly said, we need the right heart cath to determine that this is definitely out of proportion, and to mainly to look at the wedge pressure. Because a lot of those patients, they have diastolic dysfunction. For example, the COPD or the sleep apnea, the lung fibrosis. When we did the right heart cath, the wedge pressure is very high. And we say this is a combination of group 2 and group 3, not group 1. But if the wedge pressure is really normal and the disease is really out of proportion, there is many trials towards treating them with a target therapy, i.e. inhaled iloprost, sildenafil, or bosentan. And there is only small studies that address this issue, and they were inconclusive. There was some improvement in the functional class, that they feel better, but their oxygenation goes down because of the increased VQ mismatch of those patients. So any improvement in the functional class was counterbalanced by the decrease in basic oxygenation. However, we do have a few patients that we treat them with either inhaled iloprost or sildenafil. And to be honest, the result is 50-50. Yeah. We have patients, they improve significantly on treatment, and we have a patient that we have to stop the drug after 3 months because there was no good effect. So these patients nowadays are under clinical trials trying to find what is the best approach. But first of all, we need to rule out diastolic dysfunction because we think it is the most common cause of the out of proportion, basically pulmonary hypertension in those patients, which, by the way, echo almost always misguide us because our cardiologists, echo, basically they said it is a grade 1 diastolic dysfunction, and when you wedge them, the wedge is basically 25 or 30, which is really, really high. So you need the right heart cath, and then trial of therapy is probably justified. I think sildenafil is a reasonable drug, but we need to watch for the drop in oxygenation, especially with exercise.
And affordable. My second question, Magdi, is how do you perform for the group 4? I'm touching the problems of the non-PH because
Right.
we face the non-PH more than the PH.
Right.
In the problem of group 4 or the chronic thromboembolic pulmonary hypertension, do you perform the endarterectomy surgery, and what's the results of the endarterectomy? Because in our country we have the bad news about the endarterectomy. It's not that successful.
Okay.
So what's your experience in this problem?
We did in Saudi Arabia 3 cases over the last basically 2 years of endarterectomy for those patients. 2 of them did extremely very well, and they are now off treatment, and they're almost back towards normal life. The third one get initial improvement and then basically deteriorated, and probably she will need lung transplantation, this patient. Of course, it is the selection of those patients is extremely important. This patient, the one who deteriorated, she was not a candidate. She was not ideal candidate. She had very high PVR before the surgery, and those patients whose PVR is more than 1,000, they're always not doing good because almost always they have a distal basically disease. But despite that, we decided to do her because she was non-Saudi, so she will really not get lung transplant in Saudi Arabia. So we tried to give her the best that we can. She was almost dying because of the disease. We did endarterectomy. She did good improvement for about 6 months, but then she's been deteriorated since then again. And that's usually happen in those who have very high PVR basically before the surgery. So I think if you have a good candidate, it should be done. It is the only curative form of the pulmonary hypertension.
Thank you, Dr. Magdi, for this illustrative and very deeply scientific presentation. Understand that there is a wide array of drugs and agents that tackle the basic mechanisms leading to pulmonary hypertension, and there is a very fierce pharmaceutical competition in producing and manipulating.
Correct.
And what I understand also is that the endpoints of all the trials are physiologically tracked: pulmonary vascular resistance, 6-minute walking distance, oxygen saturation, and symptomatology, quality of life. But I haven't seen any progress or reversibility, if I may say, in the basic pathology of the disease. Are there any new remodelers? Are there any studies showing real parenchymal lung changes in association with this symptomatic relief? And what are your current, this is the second question, current standpoint on lung transplantation, when we should start it or apply it early or late in the disease? And thank you.
Thank you very much. This is a very good question. And the question is that, can we reverse the disease process really anyhow? Well, you are rightly saying when you said most of the clinical trial had a clinical endpoints. It used to be almost a 6-minute walk distance, because there was data to show that if somebody can improve their walk by 50 meters, the cardiac output was almost double. But however, recently, this was challenged a lot. And all the newer study will not look at the 6-minute walk distance. They will look at what they call clinical worsening case scenario, in the way that they need to have more drugs, ICU admission, or lung transplantation. However, to look at and to be honest, as a clinician, that's what we want. We want the patient to really feel better, walk longer, and we'd like to improve basically survival if we can. If you look at the survival data, IV prostacyclin definitely improves survival and almost double the survival. The other drugs There was no survival studies because it's now not ethical to do any placebo cases. It has to be patient on drug. But if you compare the current drugs with the historical control, we believe that the survival is really doubled in all of these drugs. But to go specifically towards your question, is there any data that we change the remodeling or reverse the remodeling? There is animal data for that, but there is no human data at all. It's never shown in a human that any of these drugs reverse the remodeling. But when they looked in the rat, it was mostly German study done basically in Giesing group. They looked at the rat model with those who have very hypertrophied, basically pulmonary artery. And they used bosentan or sildenafil treatment, and they measured over a few weeks. There was regression in the size of these pulmonary arteries. And actually, in two of their sample, there is complete reversal of the process. But these are only rat model. You cannot extrapolate data into human, but at least it gives you a signal that probably we are slowing the disease progression. And I think the early study which showed that early basic treatment with those patients who are asymptomatic, they had the disease, but they are totally asymptomatic, bosentan treatment slowed the progression of the disease by decreasing the progression of the PVR. But again, it did not reverse it. So there is no data in a human at all. There is animal data to show that you are modifying the remodeling process by using these drugs.
Thank you, Dr. Magdi, for a very elegant presentation. Thank you so much for your time and coming to this meeting. Thank you so much.
Magdi, we really appreciate all you are giving us. مجدي أنا عارف إنه كان في محاضرات في المنيا وفي أماكن في مصر، وكان عنده كوميتمنت لازم يرجع السعودية. رجع يعني راح امبارح ورجع في نفس اليوم عشان يكون معانا هنا. وللأسف هو مش هيقدر يحضر معانا رجالة دينر، فأنا بستأذن حضراتكم نقدم له الريكوجنيشن بتاع الجمعية دلوقتي. ده يعني تقدير بسيط من الجمعية ومن كل الزملاء ليك يا دكتور مجدي.
It's really an honor. Thank you.
اتفضل.
It's my honor to introduce Professor Yasser Mustafa. He will talk about updates on anticoagulation therapy on pulmonary embolism.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, dear professors and colleagues, my talk today will be about one of the very important and everyday practice issue, which is not interesting only for the pulmonologists, but also for internists and intensivists and ER doctors. It is about updates of anticoagulant therapy in cases of pulmonary embolism. I will jump to the management or the special issue in the management, which is anticoagulant therapy only. And this, according to evidence-based medicine, it is collected in recommendations or guidelines. And one of the most famous and comprehensive guidelines are the guidelines of the American College of Chest Physicians, which addresses a number of concerns related to deep venous thrombosis and pulmonary embolism. And these guidelines were published in July 2008. And since that time, we apply or practice these guidelines. In recent years, there are many drugs coming on. I will mention them very rapidly. And there may be a new or a recent nearby guidelines after they take FDA approval. They provide an evidence-based information on antithrombotic therapy for venous thromboembolic disease. Using a grading system, the society categorized its recommendations as strong, grade 1, and weak, grade 2. All now recommendations depend on based evidence medicine, as we know. Grade 1 recommendation indicate that benefits do or do not outweigh risks, burden, and costs, and the grade 2 recommendations suggest individual patient values may lead to different choices according to the abstract. So each recommendation of this classified or take another recommendation A, B, and C. For patients with objectively confirmed DVT or pulmonary embolism, grade 1 recommendations included anticoagulant therapy with subcutaneous low molecular weight heparin, monitored IV or subcutaneous unfractionated heparin, unmonitored weight-based subcutaneous unfractionated heparin or subcutaneous fondaparinux. In another situations, cases of suspicious of pulmonary embolism, physicians should treat patients who have a high suspicion of DVT or pulmonary embolism until the results of investigation with anticoagulants while awaiting the outcome of a diagnostic test according to grade 1 guidelines. For unfractionated heparin therapy, patients with massive pulmonary embolism, it is highly indicated if concerns regarding subcutaneous absorption arise, severe renal failure, or if thrombolytic therapy is being considered, IV unfractionated heparin is the recommended form of initial anticoagulation. The efficacy of heparin therapy depends on achieving a critical therapeutic level of heparin with the first 24 hours of treatment. The critical therapeutic level of heparin is 1.5 times the baseline control value or the upper limit of the normal range of the activated partial thromboplastin time. If intravenous unfractionated heparin is chosen, the initial bolus of 80 units per kg or 5,000 units followed by an infusion of 18 units per kg per hour or 1,300 units per hour should be given, with the goal of rapidly achieving and maintaining the active partial thromboplastin time at levels that correspond to therapeutic heparin levels, as we mentioned. Fixed dose and monitored regimens of subcutaneous unfractionated heparin are available and are acceptable alternatives. As regards low molecular weight heparin therapy, the current guidelines for patients with acute but non-massive pulmonary embolism recommended low molecular weight heparin on grade 1A baseline. Low molecular weight heparin have many advantages over unfractionated heparin. These agents have a greater bioavailability. They can be administered by subcutaneous injection and have a longer duration of anticoagulant effect. And trials comparing low molecular weight heparin with unfractionated heparin have shown that low molecular weight heparin is at least as effective and as safe as unfractionated heparin, and the studies have not pointed to any significant difference in recurrent thromboembolic events, major bleeding, or mortality, the same side effects. So a fixed dose of low molecular weight heparin can be used, and lab monitoring of active partial thromboplastin time is not necessary. It can be administered safely in an outpatient setting. This is another advantage. This has led to the development of programs in which clinically stable patients with pulmonary embolism are treated at home at substantial cost saving. And in a big trial published in Lancet 2011, it is an open label randomized trial compared outpatient and inpatient treatment using both low molecular weight heparin enoxaparin as initial therapy. Comparing it with unfractionated heparin, it was found that for instance, for patients with low risk, patients with hemodynamic instability should be hospital admitted. Acute pulmonary embolism, and concluded that outpatient treatment was non-inferior to inpatient treatment. Fondaparinux is a synthetic polysaccharide derived from the antithrombin binding region of heparin. It catalyzes factor 10 inactivation by antithrombin without inhibiting thrombin. So it has not been directly compared with subcutaneous unfractionated heparin or low molecular weight heparin, but once daily fondaparinux was found to have similar rates of recurrent pulmonary embolism, bleeding, and deaths as IV unfractionated heparin. So it carried the same incidence of side effects according to a randomized open-label study on 2,213 patients with symptomatic pulmonary embolism. Now the duration of heparin in treatment of acute pulmonary embolism or DVT, initial treatment with low molecular weight heparin, unfractionated heparin, or fondaparinux for at least 5 days in patients with acute DVT or pulmonary embolism. This is plus vitamin K antagonist. The heparin preparation should be discontinued when international randomized normalized ratio, INR ratio, reach more than 2 for at least 24 hours. Vitamin K antagonist, the most famous as warfarin therapy. The anticoagulant effect of warfarin is mediated by the inhibition of vitamin K dependent factors, which are factors 2, 7, 9, and 10. The peak effect does not occur until 36 to 72 hours, so they are slowly acting drugs. And the dosage is difficult to titrate. A prothrombin time ratio is expressed as an INR and is monitored to assess the adequacy of warfarin therapy. The recommended therapeutic range for venous thromboembolism is an INR of 2 to 3 of the baseline. Initially, INR measurements are performed on a daily basis. Once the patient is stabilized on a specific dose of warfarin, the INR determination may be performed every 1 to 2 weeks or at longer intervals. As a whole, duration of anticoagulant therapy according to the guidelines, patients with first thromboembolic event occurring in the setting of reversible risk factors such as immobilization or surgery or trauma should receive warfarin therapy for at least 3 months. There were a debate about 3 months or 6 months, so there is a study published in British Medical Journal 2007 stated that no difference in the rate of recurrence was observed in either of 2 studies comparing 3 versus 6 months of anticoagulant therapy in patients with idiopathic or what we call unprovoked first event. So the current recommendation is anticoagulation for at least 3 months in these patients. The need for extending the duration of anticoagulation should be re-evaluated at that time. We leave this to the certain circumstances guided by the treating physician. The current ESSB guidelines recommended that all patients with unprovoked pulmonary embolism should undergo a risk to benefit evaluation to determine if a long-term therapy is needed on grade 1C evidence-based. Long-term treatment is recommended for those patients who are not have risk of bleeding and in whom accurate anticoagulant monitoring is possible. This is a very important issue. Then if patients still are receiving the anticoagulant therapy and they don't follow their INR. Patients who have pulmonary embolism and pre-existing irreversible risk factors such as deficiency of antithrombin 3, protein S and C, or factor 5 Leiden mutation, or the presence of antiphospholipid antibodies should be placed on a long-term anticoagulation. Certain situations, recommendations for patients with lung cancer, we know that those patients have a paramalignant manifestations. One of them is recurrent superficial thrombophlebitis and migrating thrombophlebitis and sometimes deep venous thrombosis, which may affect both upper and lower limbs. First, unprovoked proximal DVT or pulmonary embolism, and second, unprovoked attack indicate heparin therapy. Vitamin K antagonist doses should be adjusted to maintain an INR level of 2.5 for the duration of all treatment. Those patients should receive at least 3 months low molecular weight heparin, followed by treatment with low molecular weight heparin or vitamin K antagonist until the cancer is inactive. The ACCP recommended that an elastic compression stocking be used to prevent post-thrombotic syndrome after proximal DVT. And treatment similar to that for DVT of the leg is also recommended for DVT of the upper extremity. Patients with lower and upper extremity DVT may consider for thrombus removal using catheter-based thrombolytic techniques. Prophylactic is very important for 4 weeks of intermediate doses of low molecular weight heparin or unfractionated heparin in patients with extensive superficial vein thrombosis to prevent deep vein thrombosis. Another clinical situation which is very important in clinical practice is heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is a transient prothrombotic disorder initiated by heparin. The main features are thrombocytopenia resulting from immunoglobulin G-mediated platelet activation and in vivo thrombin generation and increased risk of venous and arterial thrombosis. The highest frequency with unfractionated heparin may reach up to 5%, reported in post-orthopedic surgery patients receiving up to 2 weeks of unfractionated heparin. It may drop to 0.5% in patients receiving low molecular weight heparin. That's with low molecular weight heparin, the incidence of heparin-induced thrombocytopenia is less. It manifests clinically as extension of the thrombus or formation of a new arterial thrombosis. Should be suspected whenever the patient's platelet count falls to less than 100,000 per microliter or less than 50% of the baseline value, generally after 5 to 15 days of heparin therapy. The definitive diagnosis is made by performing a platelet activating factor assay. Its treatment is to stop all heparin products, even flushing of catheters or arterial cannulas should be stopped at all, and to initiate an alternative non-heparin anticoagulant even when thrombosis is not clinically apparent. Preferred agents include direct thrombin inhibitors such as lipirudine or argatropan. Start warfarin while the patient receives an alternative non-heparin anticoagulant, but only after the platelet count raised to at least 100,000 or preferably to 150,000. The other clinical problem with heparin is resistance to heparin or failure to prolong authorized in the activated partial thromboplastin time, although the patient is receiving the full dose. Few patients with venous thromboembolism require larger dose of heparin for achieving an optimal activated partial thromboplastin time. Those patients who do require them have increased plasma concentration of factor VIII and heparin-bind proteins. Increased factor VIII concentration causes dissociation between active PTT and plasma heparin values. The active PTT is suboptimal, but patients have adequate heparin level upon protamine titration. This commonly occurs in patients with a concomitant inflammatory disease. Monitoring the anti-factor 10, active 10 assay results in this situation is safe and effective and results in less escalation of the heparin dose when compared with monitoring with active PTT. Whenever a therapeutic level of active PTT cannot be achieved with large doses of unfractionated heparin, either determination of plasma heparin concentration or therapy with low molecular heparin is preferred. We should switch to low molecular weight heparin, which does not need a monitoring with BTT. Lastly, in the last few years, we have new drugs acts only on active factor 10 inhibition, and the goal for researchers is to provide a simple, safe as regards the complication and side effects, and simple in taking the treatment as regards the frequency and the way of administration. It is better to be oral, and effective drug without a concomitant side effects. Recently, rivaroxaban, as we mentioned yesterday by Professor Dr. Tariq Safat, is an oral factor 10 inhibitor, provide a simple fixed dose regimen for treating acute DVT and for continued treatment in chronic cases without the need for lab monitoring. Approved by FDA for prophylaxis in post-operative period after knee and hip replacement and in chronic AF. Nearly, it will approved for treatment of acute pulmonary embolism. Its antidote is thrombin complex concentrate. This is not actually my issue, but I like to mention what the indication for recommendation for fibrinolysis in acute pulmonary embolism. It is very important in clinical practice to categorize the patient with acute pulmonary embolism whom will receive fibrinolytic therapy in the form of tissue plasminogen activator or streptokinase or urokinase. Fibrinolysis is reasonable for patients with massive acute pulmonary embolism and acceptable risk of bleeding complications. This is class 2A level of evidence B. Fibrinolysis may be considered for patients with submassive acute pulmonary embolism judged to have clinical evidence of adverse prognosis. For example, new hemodynamic instability, worsening respiratory insufficiency, severe right ventricular dysfunction, or major myocardial necrosis, and low risk of bleeding complication. Fibrinolysis is not recommended for patients with low-risk pulmonary embolism or submassive acute pulmonary embolism with minor hemodynamic instability in the form of right ventricular dysfunction, minor myocardial affection, and no clinical worsening. Fibrinolysis is not recommended for undifferentiated cardiac arrest. And thank you.
شكرا دكتور ياسر.
شكرا جزيلا ياسر مصطفى. This valuable talk and elegant presentation.
دكتور محمد اتفضل. علي صوتك بقى. علي تسمع.
Actually, my question to Professor Dr. Tariq Safar, as regard pulmonary hypertension management in Egypt, I want to ask you, sir, about your experience with the era of use of sildenafil in the market now, from chest physician and cardiology physician, with dealing with primary or pulmonary hypertension due to COPD, interstitial lung disease. Because there's many patients now treating with these medications. I don't know what's about your experience with this.
هو طبعا كان في ايكو يا محمد وانت بتكلمني او بتتكلم على البالمر هايبرتنشن في ايه؟ هو ده الامكانياتنا في البالمر هايبرتنشن في البي اتش او نون بي اتش. فهو انا بستعمله في الحالات اللي هو بقى خصوصا في الجماعه اللي هو لما بعمل لهم احنا ما بنعملش الرايت هارت كاس للاسف، وما عندناش لسه سنترز ويل ديفلوبد للبالمري هايبرتنشن ولا في البي اتش جروب اللي هي جروب 1 ولا في النون بي اتش اللي هي جروب 2 3 4 وات ايفر. احنا الجروب بتاعتنا اللي احنا بنقع فيها هي الجروب 3 اند 4. دي المشكله بتاعتنا بالظبط. دي اللي اكتر حاجات اللي بنشوفها. طبعا الجروب 1 برضو في عندنا اللي فيها بتوع الليفر سيروزس والحاجات اللي هي الهيباتيتس سي فيروس اكسترا. لكن اللي عايز اقوله والفاسكولايتس اللي هي بتاعت الحاجات زي سكليروديرمز والحاجات دي. اللي انا الاكسبيرينس بتاعتي ان بدي الفوسفودايسيز 5 انهبيتورز في حالات اللي بلاقيها فيها سيفير بالمر هايبرتنشن باي ايكو. وخد بالك برضو بنأكد على بتوع الايكو ما بيهتموش بالرايت بريشرز، فدايما بنقول لهم من فضلكم لو انا شاكك بليز تشيك البالمري بريشر. طبعا هو مش بدقه زي ما قال الدكتور مجدي، مش بدقه الرايت هارت كاسترايزيشن، لكن لو لقيت اوت اوف بروبورشن بالمري بريشر مور ذان 45 ملم ميركوري ممكن اكتب السلدنافيل، وبتديه بكونسنتريشن معينه اللي هي 75 ملي جرام تو ستارت وذ 20، فبتقدر تقسمها ل 25 25 25. النقطه اللي عايز اقولها كان بالنسبه هي اهم حاجه في الموضوع قبل ما تبتدي تدي حتى السلدنافيل والحاجات دي، انك انت يو كنترول التشست بروبلم بلونج تيرم اوكسجين ثيرابي، لو محتاج برونكو دايليترز، محتاج ستيرويدز، وات ذا اند اوف ذا ستوري انك بتدي الحاجات اللي هي بتاعت البالمري بريشر. اتفضل يا مهندس.
طبعا عشان البلمونري هايبرتنشن والسيفيريتي دكتور مجدي ادريس كان محق تماما ان الرايت كاردياك كاثيتر ذا جولد ستاندرد وان الايكو از سكريننج. لكن الحقيقه دلوقتي في نيو اتشيفمنت حصلت، ويعني بقى لها كذا سنه ماشيه، اللي هي المالتي سلايسد كمبيوتر توموجرافي which is ECG gated synchronized مع الاي سي جي. ده برنامج بيتعمل وبيقيسوا بيه حاجه مهمه جدا جدا اسمها البلمونري ارتري ديستنسبيليتي ريشيو. الديامتر بتاع البلمونري ارتري في السيستول والدايستول، والريشيو دي لقوها انها تساوي البلمونري ارتري بريشر in its significance او in its implication as a parameter of pulmonary hypertension. فدي نون انفيزيف تكنيك موجود دلوقتي وموجود في الليتريتشر، بتعمل عليه ستاديز كتيره قوي عشان يخلينا، لان مش كل واحد حتى تقدر تعمل له رايت كاردياك كاثيتر، ولا كل سنتر فيه فاسيلتيز لرايت كاردياك كاثيتر. لكن الاي سي جي جيتد مالتي سلايسد سي تي اوف ذا تشيست تقيس البلمونري ارتري ترانك ديستنسبيليتي ريشيو الدايستول والسيستول، وتطلع منها ابتدوا يحطوا المقاييس بتاعتها. انا مش فاكر الفيجرز لكن اتس فيري امبورتنت بوينت. شكرا.
احنا بنشكر المتحدثين دكتور مجدي ادريس ودكتور ياسر. طبعا احنا وير بيهايند سكادجول حوالي نص ساعه. الكوفي بريك بره ممكن ندخلها هنا جوه لو حبيتوا، وهنجتمع تاني بعد ربع ساعه، 1:15 ان شاء الله.